Hi guys, in this video we'll be discussing about inherited metabolic liver diseases, and the contents include the overall definition of inherited metabolic liver diseases, which are hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. And for each of them, we're going to go over the description of the disease, the pathogenesis, and the relevant pathological and clinical findings. So, starting off with hemochromatosis. What is hemochromatosis? Is basically excess iron in the blood, which can then deposit in tissues. It's termed hemosiderosis. Generally, a slow progressing disease, more common in men than women, as the menstrual cycle is protective. With menstruation, there's loss of blood, and with loss of blood, there's also loss of iron. Hence, it takes longer for it to occur in women. And it also generally requires more than 20 grams of iron levels for symptoms to arise. Why is iron accumulation a bad thing? It's because iron is a charged particle and it can take part in the redox reactions within the cell, giving rise to reactive oxygen species, which can damage almost all components of the cell, mainly the plasma membrane. And once the plasma membrane becomes dysfunctional, the cell basically will die. It's divided into primary and secondary hemochromatosis. Primary hemochromatosis is an autosomal recessive inherited disorder. It is the mutation of the HFE gene, which encodes for the HFE protein. Now, how this works is a normal HFE protein is required by the hepatocyte to sense iron levels in blood by interacting with the transferrin, the iron transporter protein. When there's a mutation, there is no possible communication between or interaction between the HFE protein and the transferrin. Hence, the hepatocytes are not able to regulate and sense the level of iron. Lack of interaction also is taken as no iron or less iron in blood by the hepatocytes. Hence, what they do is they decrease hepcidin, which is a hormone produced by hepatocytes regulating iron uptake by enterocytes. When there is low levels of hepcidin, it allows for the enterocytes to uh, uptake more iron from the lumen and then push that iron into the blood from the basolateral membrane. So low hepcidin, more iron basically means it's going to be depositing over time once the amount becomes significant. Then you have secondary hemochromatosis. This is an acquired trait. It's mainly due to repeated blood transfusions. And the clinical manifestation and complications include in the liver, the ROS production damages the hepatocytes, and over time, damage hepatocytes. Uh, Basically, over time, it leads to cirrhosis. The main morphology of this is dark brown to red liver because of the iron accumulation. And then you have the skin. In the skin, iron can also deposit, leading to bronze skin. In joints, it causes arthritis. In the pancreas, secondary diabetes mellitus, how basically the accumulation in the islets uh, messes with the insulin secretion. And when the insulin secretion is reduced or absent, it will cause hyperglycemia, and prolonged hyperglycemia transitions into diabetes mellitus. And then in the heart, it causes restrictive cardiomyopathy by deposition in the myocardium, can cause arrhythmias if it involves the conduction system as well, and can cause heart failure. It also increases the risk of infection because bacteria require iron for proliferation and growth. With increased amounts of iron in blood, this gives easier access for these bacteria, for these pathogens, for proliferation and growth. Hence, there is a higher chance of you getting infection. Next, we have Wilson's disease. Wilson's disease is also an autosomal recessive inherited disorder of copper metabolism. Again, copper is reactive, like iron, participates in the Fenton reaction, can also cause ROS formation. Now, what is the pathogenesis of Wilson's disease? Basically, it's also a mutation in one of the copper-related proteins. It's called ATP78, a copper binding protein. So normal function of ATP78 is that it binds copper to ceruloplasmin, which is the plasma transporter for copper, and it also helps it get released from bile in case it is excessive. So lack of functioning ATP78 l- makes these two main functions absent, and once these are absent, it starts accumulating in the liver, obviously, and can also start accumulating extrahepatically in other sites. And the clinical manifestations that you see within the liver are ROS formation and damage to parasites and over time liver cirrhosis. In the CNS, we get neurological deficits due to copper deposition, such as dementia, chorea, and Parkinson's symptoms. In the eyes, you see Kaiser-Fleischer rings, as you can see in this picture, that bronze brownish deposition ring around the in the cornea. It's copper deposition. It's an interesting clinical find. And in kidney, it causes Fanconi syndrome, which is basically lack of reabsorption in the proximal tubules because of the copper deposition. And finally, we'll be discussing about alpha-1 antitrypsin deficiency. Again, an autosomal recessive inherited deficiency of the enzyme alpha-1 antitrypsin. Now, the normal function of this enzyme, the physiological function of this enzyme, it is one of the enzymes which is there in inflammation, and it is a protease inhibitor. Its function is to prevent the proteases that are released and formed during inflammation to cause any harm to normal healthy cells. So, if you have a deficiency or a mutated version of this, so it won't be able to function properly, and the proteases would be in excess, leading to damage, unwanted damage to even healthy cells and tissues. Uh, then we have the severity of the disease is based on the genotype of the individual. So PIM is the normal dominant allele, whereas PIZ is the most significant mutated recessive allele, clinically significant one. So if an individual is with the phenotype, sorry, genotype PIM, so this is a healthy individual with the normal enzyme, uh, and there are no symptoms, no issues with this individual. Whereas if an individual is PIM and PIZ, heterozygotes, they're usually asymptomatic, or even if they show any signs, it's going to be very, very mild, nothing severe and life-threatening. However, people who have PIZ who inherit both recessive copies are a significant risk because, as compared to heterozygotes, they have produced misfolded enzyme. The chance of them producing a misfolded enzyme is quite low. However, for people who have PIZ, for them producing this defective enzyme, the chances are very high. Most of the enzyme which is being produced, of this enzyme which is being produced, is mutated and non-functional. Hence, they are at a greater risk of developing pan-acinar emphysema and cirrhosis. You can check out more about pan-acinar emphysema in the respiratory section, and cirrhosis because it starts accumulating within the liver, and misfolded protein accumulation is damaging to cells. It affects the cellular functions and leads to necrosis, and these cells die, and over time you get liver cirrhosis. So, so this is a straightforward, simple question. You should know all of them are autosomal recessive inherited traits. You should be able to tell the complications because they are important. And apart from that, there's nothing much else to be said about this question. Thank you, guys.